the pathway of least resistance, and it's actually displacing up towards you. Because I don't really know how I cut it any other way. Fortunately, Alan Bishop came in and repaired it, and she did really, really well with the repair, but it was pretty traumatic experience for me to cut somebody's nerve like that. I would just say, be very careful with that. Obviously, and I think we probably all do, we generally tend to strip the capsule off the humerus, but this was so scarred I was using a knife as well.
Congratulations, because I think we do have, thanks to you and Graham and Ken, and elbow that I actually trust in younger patients as I have. So I get the impression that over the last 5 to 7 years, in my primary only, the infection rate has been actually low. I think also one benefit of this exposure is that the flaps are less. And then I have migrated, to using a back sponge in every elbow. So do you know, in these 200 and some cases, what was your infection rate if you look at just primaries or have a sense? And what have you done over your practice to take that complication out from the practice? Because traditionally people would quote over 5%. And I think it's less than that in contemporary primaries.
I agree with you. I don't know for sure what my infection rate was overall. I wish I could give you a number, but
Okay.
I'd
primaries
you know, 0.9.
So under 1%.
Under 1%.
Under 1%.
For primaries. And for revisions?
No, revision is different.
Yeah,
Because
very different,
many
yeah.
revisions are infected and we don't know about it. But in the primary setting, if you read papers, everyone quotes 5%, 6%. Some papers quote 12%.
I know.
And I think one benefit of this exposure is also minimal flap raising. The skin heals very nicely.
Right. I think that's a profound difference, quite frankly. We generally had concerns, about the skin flaps in the past, and I virtually never have a concern about the skin now. So minimizing the skin flaps, minimizing the dead space in the subcutaneous region. My sense is that the infection rate is way lower than we used to say that it was for a primary. I just don't know what my rate is for those. When I was looking at the post-traumatic cases that I did, I think I forgot the number that we have. And Valeria, do you have 2% in post-traumatic? And when I looked at that a few years back, when we first started looking at them, I went back through the whole history of each of the patients that got infected. And I could determine that although they got infected, there was something that explains the infection very clearly. And Valeria, do you know, are you familiar enough with the patients who got infected to speak to that issue?
Had multiple operation before
Right.
and probably also some open wound for the first incident.
Right. And that was before I started taking the biopsies as well, like we started doing, so if there's any suspicion for it. So my sense would be that if I had biopsied some of those people, I might have determined that they were actually, there was residual infection left over, but I don't know for sure. But
one of the things in my practice that I'm curious about your IBS is in patients that have had a prior surgery and you have your antennas up about infection and they have no retained hardware. I used to do a full exposure, repair the canals, like do almost the operation, but then don't implant. And then I will come back 3 weeks later to do the implantation. And I think those two major hits on the soft tissues are huge. So now what I do is I do a triceps split for biopsies. Otherwise you don't have to remove. And that's like really no morbidity. What do you think about that, Sean? You do them arthroscopically yourself.
did them arthroscopically, and I forget how many I did altogether, but it was between 10 and 20. I think it was in the mid-teens. And I picked up 2 infections that I didn't have any reason to suspect otherwise were infected. So, yeah, I think it exists.
Mark, when you stage an elbow today, do you do like the full canal preparation, bone cuts and stuff, or are you more minimalistic in the hardware out, take some biopsies, and then do the big surgery at the time of implantation?
I mean, if I'm gonna put a spacer in, then I'm doing the big operation.
How about if you?
But if I don't know, I'll do it arthroscopically. So I had a pilot for Delta. This is the most recent one, and I wasn't sure what I was going to do, and I didn't know if he was what the condition of his joint surface was, and whether or not I could fix it or he needed a total elbow. So I did arthroscopic biopsies. He had non-union and he was infected. So I did, arthroscopic biopsy at the non-union site. I mean, it was super minimalistic, but it gave us the data to then stage him subsequently. I don't think so. I mean, it's pretty low morbidity.
It would be a minimal difference.
To do the case with no setup,
Right.
no
Right.
pump, no. So I don't know if arthroscopy is really of value, but I don't get to the anterior compartment though. I just go triceps split and take the biopsy from the rectal first.
Yeah, I think the reason I chose arthroscopy for that, and I wanted to see whether or not there was a non-union. So I got in there and it was not, I could, see. I like to see. I don't know.
Then my last question, Sean, is not for a patient, but if you had a partner, like for example, if I needed an elbow arthroplasty, weight training for
Maybe drive more than 90 miles an hour on the way to the airport. Yeah. Well, I tell everybody the very same thing, which is that there are two things you can control that will influence, I think, how long this lasts. And that one is how many times it gets used, how many cycles of use, and the other is how hard each cycle is. And that's up to you to do that. So if you're going to break, away at ice and do heavy gardening, moving stones and things, then it's probably not going to last as long as if you don't do that. And other than that, I think that most of the factors are really probably out of your control.
golf, tennis.
So let people do whatever they want and tell them that it's your elbow, not mine. You decide how hard to use it, like you decide how hard to be on your car or anything else. That's up to you. But you need to take responsibility for it. And I explained to them importantly that just like Mark talked about the varus load, that the torque on the elbow when you reach and grab something like this is a lot harder on the elbow than what you lift like this. But I learned, with the study that John Barlow published, that, our patient, 90% of them didn't do what we told them to do anyways. But I stopped telling them those limitations a long time ago. It's more than 20 years. I stopped telling them before we had this prosthesis, actually. And that was on the basis that I had a patient who began to cry when I told her about the limitations, and I thought I'd said something to offend her, upset her. I asked her what the problem, what have I said? And she said, well, I have a however old granddaughter, my first granddaughter, and now I'm not gonna be able to lift her. And I just remember thinking to myself, I just gave this lady a life sentence, the thing that brings her the most joy in life. I just told her she can't do that. So I said, well, you go ahead and lift your granddaughter, but get somebody else to carry the groceries and do the snow and all that kind of stuff.
Meanwhile, I had Paul chopping wood, he didn't listen anyway.
Well, people don't have the means to hire a company to take care of your snow in Minnesota. So you can tell them don't do it, and it's like, well, I'm trapped. There is 2 feet of snow, and I have no money to pay a company. So that's why John Barlow's paper is so good, because people said, "What do you want me to do?"
Yeah, right.
No one is to take my snow.
You want me to stop living?
Exactly. So I had to get out of my house. So I'm gonna do
But
this.
it is unbelievable the number of patients that come in and say, well, I don't want the total elbow because of the restrictions of the total elbow. Every single patient that comes in, I have that conversation about these are guidelines, and it's like a car. I use the same analogy that Sean uses.
The reason for that, Mark, is that the healthcare providers are sending that.
Oh, yeah. There's no question
with a
about it.
family doctor, PA.
They're just frankly saying total elbows don't work, which is a lie.
A secondary question about that. You talked about implant companies not going after this market, and my question is, if any you guys are design surgeons, and if there's been any softening of that, the rate of total shoulders needed continues to sort of skyrocket. Older patients are more active. I would guess that there's a lot of patients out there. If we continue to evolve this, we're at a really nice point, but highly cross-linked polyethylene, vitamin E doped polyethylene. Think about we're at a Stryker meeting and think about pyrocarbon. Hemiarthroplasty would be great. My sense would be there's a lot of patients who could have total. The market is bigger than what is even being explored right now. Do you have any sense of softening or movement toward that, toward continuing to evolve this system?
Oh, at Stryker?
No, there's zero.
It's really frustrating.
And as a matter of fact, so they can no longer use the latitude in the Netherlands. So Roger can't get it.
Okay.
Denise can't get it. It's not uncommon. I don't know about you, but it's not uncommon for them to say, "Oh, we don't have the medium."
Yeah.
And it's like, well, we don't have an elbow, So I'm very concerned about it.
So it's actually the latitude is currently getting harder to get.
Yes. Oh, we have a long stem, so now I'm cutting the stem. Have you ever used the Latitude without cement?
I did. I think it was, I looked it up. I think it was 6 components I did without cement, 5 or 6 in 4 patients, I think it was. I think I just had 1 patient, which I did both components. And I revised, if it was 5 components, I revised 3 of them. If it was 6, I revised either 3 or 4 of them for loosening. Well, actually, one of them I revised that I thought had to be loose, but it was not. I mean, it took enormous pounding on it. I went back on this patient. This was a young, well, not young, 53-year-old man who was an amateur golfer. His expression is, I live to golf. He was a finance guy. I live to golf. And I eventually replaced his elbow and did both sides unlinked. His ulnar component loosened. He had pain in his ulnar like this, and I went in. I was sure it was loose. Radiographically, it didn't look loose, but I was sure it was based on my knowledge of how radial stems behaved. So I went in, and it was it wasn't grossly loose, but I could tap on it. It came out easily. So I cemented it. That pain went away. Developed humeral pain, like in his distal humerus, not at the elbow, in the humerus. And I went in at some point to take his humeral component out, and it was completely solid. I couldn't see any evidence at all. I tapped on it, not really, really hard, and I was convinced it was not loose. His pain persisted. I worked him up extensively for infection, all kinds of things. And eventually I said, it's got to be loose. It just has to be loose. So I went in and I thought, I'll just take it out. But I had to pound and pound and pound on that thing to get it to move at all. And I cemented in a new one. Of course, his humeral pain never went away, sadly. He ended up with an unsatisfactory outcome. Really sad.
Your point, John, is very well taken. The market of patients that need the operation is out there, So if companies knew, they would.
Yeah, there's no question. There's no question.
There's an opportunity to basically have 100% of the market probably if you
No
have
question.
if you just.
Any residents, fellows, anybody else?
It's really frustrating. I mean, I was really hopeful with the advent of 3D printing that then we would be able to have custom prostheses or lower, so the inventory would be less for companies. But it just hasn't. I mean, I can get a custom prosthesis from Restore 3D, but it costs $100,000.
It's not quite that
much.
It's a lot.
Sure.
Regarding the diamond pop approach that you mentioned, that is tremendously more stable than the repair than the parallel approach. How would you explain that? Is that you can make a much more robust repair on the ulna than the?
I haven't got all day to talk about this. Here's why. Imagine that my body is the humerus, and this computer is the forearm, and my arms are the ligaments. So if the elbow is extended in this position, the forearm is up there, and these ligaments are here. When I flex the elbow, then the forearm comes here, right? Okay, so how much movement is there at the humerus? Everything is shearing at the humerus, right? How much movement is there at the forearm? Okay, like virtually none. You can hold with a couple of fingers, right? So the demands that the ulnar insertion of the ligaments have to meet are very, very, very low. The demands that the humeral side have to meet are exceedingly high. And on the forearm side, you have, even with the ligaments detached, you have this sleeve of tendon and muscle tissue that's bonded with the ligament up here, that goes past the insertion and behaves functionally as though it's a ligament. They are ligaments. It's like if you detach the deep insertion of the medial clara ligament of the knee and got the superficial, the whole sleeve of tissue attached. There's only just a little bit of valgus blocks. If you just cut right across it, of course, it'll open up, right? Same thing here.
So I've done several patients rheumatoid very bad bone where I want to repair the ligament on the ulna, and the bone is just tearing through. And so I didn't repair it. I just brought the sleeve of tissue up. Those patients are stable because it's an inherently stable position for the elbow to be in.
And we've got a really nice biomechanical study that shows a profound difference between the two, which is just, for me, just proving what's obvious to me, but it's not obvious to most people.
Yeah, that's on the press.
Okay.
Why, like in terrible triads, MUCL injuries, why the ligament usually tears from the humeral origin?
So when you have a posterolateral rotatory mechanism, if I or in what's that, the mixed martial arts or something, you were trying to dislocate the person's elbow, you'd want to do it the least simplest way, right? And when you torque the elbow into posterolateral rotation and valgus, and it starts going around the back, the stress is located at the humeral side, and that's where everything gets stripped off. And it's for the same reason I just mentioned, that the demands on the humeral side are enormous.
Right.
And they fail when the elbow dislocates, obviously. And it's because the demands on that humeral attachment are so high that it fails.
You also have the articulation, so you've got a big cam. So you've got a shorter, you got a much longer lever arm, so then it's easier to detach that side because you've got a cam there,
He's from Dr. Camp's service. This is a 19-year-old male right-hand dominant collegiate pitcher with a 14-month history of right elbow pain. So 14 months ago, he was throwing baseball in the outfield when he slipped on grass mid-throw and felt a pull and tightness and pain to his medial elbow. He was shut down for pitching for 10 months, and he started a return to throw program 4 months ago. 1 month ago, he completed 2 bullpen sessions before re-aggravating the right medial elbow pain with discomfort in the first inning of a game. Currently, he comes to clinic with a 3 to 4 out of 10 baseline pain, up to 8 to 9 out of 10 pain when throwing. He tells me that his baseline pitching velocity was 85 to 87 miles per hour. With kind of like all the rehab, his pitching velocity topped at 82 miles per hour, and he felt that he had lost command of his pitching. Associated symptoms included paresthesias in the ring and pinky fingers, as well as right elbow crepitus and popping with elbow flexion and extension. And the SANE score was 60. He's otherwise healthy, doesn't take any medications, no tobacco products, and he's a freshman pitcher in junior college. So for JR, Prince, and Michaela, you can help them. This is a 19-year-old pitcher presenting with medial elbow pain, paresthesias in the ring and pinky fingers, and crepitus and popping with elbow range of motion. Why don't you guys just each list kind of like something you would do for his physical exam with your what you suspect his injuries are. Yeah, with like the paresthesias in the ring and pinky finger, that's a really good idea. You're thinking about kind of like ligamentous instability, perfect.
How do you do that, Michaela? How do you to test the medial collateral ligament?
I would test it in almost full extension, and
So are you familiar with the moving valgus stress test? Remember, it's like you're milking a cow, and you just pull like this. But moving valgus stress test reproduces so as you take the person through a range of motion, it's the shear Dr. O'Driscoll described it. So that's very sensitive and specific for medial collateral ligament injuries.
So this, very importantly with these patients, is to consider all of the things that can create this type of symptom complex, and not just land on an alternate collateral ligament problem. So I suspect this patient has a subluxating medial triceps that's painful, and the nerve is subluxating or dislocating with it. There's an uncommon condition that I am going to report sometime soon of a ruptured anconeus epitrochlearis muscle in throwers, or an attritional injury from repetitive throwing as well, causing medial elbow pain and ulnar nerve symptoms. So be thinking about that, because you'll miss both of them if you don't think about it. The latter, not yet reported, so unless you're aware of it, you'll probably miss it anyway. That's number 1 and 2 on my list.
One more thing, crepitus, not being mechanical symptoms. So if you have a deficient medial collateral ligament, what do you overload?
I think what you said, Sean, philosophical is very important, because in medical school, we get trained to get a number of symptoms and signs and get one unifying diagnosis. And for the shoulder at the elbow, so many times there is multiple structures that contribute for the shoulder, AC joint, biceps, rotator cuff, and osteocyte. Same thing for the elbow. So you can easily say, oh, this is an ulnar nerve, but maybe three other things that also contribute to the patient's symptoms.
If he's a pitcher and it's his throwing arm and he has a subluxating ulnar nerve, then there's about a 99.999% chance that he has a subluxating medial triceps. And the pain at the elbow is almost always caused by the subluxating triceps. The symptoms in the hand, of course, are from the nerve. So if they're dominantly hand symptoms, the problem is predominantly related to the nerve. Predominantly pain at the elbow, unless it's neurogenic type pain, if it's just mechanical pain related to throwing, that's usually related.
Less popping, right? And so have like this be so dramatic. I mean, we've got tons of videos of people who are just popping over the medial epicondyle.
Dr. Camp's rotation has also been excellent for like a Canadian with not much baseball experience. Young pitchers are telling me about their like velocity from sessions, pitching with high intent. I was like, well, aren't you always pitching with like intent?
Here now, you'd be so proud. He's locked up. You can graduate.
But you take baseball, right? You're playing baseball now. Just kidding.
So his range of motion 0 to 135, extension flexion, 85 tonal supination, really kind of 5 out of 5 strength with no pain in biceps, triceps, pronation, and supination. Negative for crepitus. In terms of his pertinent positives, that posterior elbow exam, he does have some painful posterior impingement. Medial elbow exam, he was tender to palpation over the MUCL at the origin, and he did have a positive moving valgus stress test. Medial elbow exam, he had a subluxating ulnar nerve and a positive Tinel sign. And on the lateral elbow exam, he had a positive radial capitellar shear test.
Snapping or subluxating medial triceps, I think, is really important too. I think that gets incredibly, it's very common that is overlooked. And one of the things that I do think that you can have medial elbow pain just from an ulnar nerve problem or a triceps problem. It may not necessarily be the ligament. And I don't know how to distinguish it specifically, but one of the things I think is helpful is that if you have somebody who has a subluxating ulnar nerve, when you do the moving valgus stress test, when you get them in flexion, it's going to subluxate, and then when you extend them, it's going to pop back. So I think that you could potentially maybe get you get pain from the nerve during a moving valgus stress test in that clinical scenario. So one of the things I think is helpful is that if they do have a subluxating ulnar nerve, is to put your thumb over the medial epicondyle. And I actually like to, before applying the moving component to the test, just load them in valgus while keeping the nerve behind the medial epicondyle. And I think that might be a good way to isolate the ligament to see how much pain's coming from the ligament, and then actually do the moving portion of it as well. But I don't know if that's the case or not. What are your thoughts?
Yeah. No, I completely agree. I should mention that I believe you can have a false positive. It's really sensitive and specific test. You can have a false positive if you have a painful subluxating medial triceps and nerve. So having said that, I think what you can say for sure is if the triceps and nerve are giving you pain separate from the ligament, and you do that by starting in full flexion, and then you give the strong resistance and have them extend against your resistance, strong resistance, and you have them extend, that will reproduce the pain they have throwing. The second is that you start in extension where the nerve and triceps are back behind. I like to use my index finger here. And then as you come up here, you feel the nerve pop, and then the triceps go under your finger. And then what you do is be sure that the nerve is passed, and then separately palpate the nerve, move it back and forth with a little bit of compression to it. That will, if the nerve is painful, that'll clearly give them their symptoms. But then with the nerve in front, now grind the triceps muscle against the back of the epicondyle. And if it's symptomatic, that will really hurt them. That'll be the pain they get with throwing. So you can separately assess those things. I, of course, rely on the moving valgus stress test for the ligament. But if you have a false positive, I don't know how to tell that it's falsely positive.
I recently had a pitcher who had his nerve moved, and he came. Were you in that case? And all we did is, and it was all medial triceps. And all we did is the medial triceps. That took care of his pain like in 2 weeks.
The difference between treating his ligament and treating the triceps and nerve is an enormous difference.
Oh, yeah.
So given that this happened, the onset was with a single throw, I reason that it's relatively unlikely that at the same time during that throw, you tore your ligament and you caused your triceps tendon and nerve to become symptomatic. I reason that the event was a triceps event with the nerve. That was what the event was mechanically. So I would treat this patient only on the base side, unless his elbow put up widely, for example, then I do the ligament as well. But say that's the right way to do it, but that's how I would think about it, because his rehab would be short. He would, unless he's an exception to the rule, he'd be back doing his full sport at 3 months. And if he wasn't able to, then it's his ligament as well.
But this kid's got ligament plus OCD.
Not the lateral side is abnormal.
And before we did not get us too far off track, he did not have a subluxating or snapping triceps. This kid did not.
I would share with you that I have yet to see a patient.
So he does on exam when you grind it, he has symptoms, but he comes in pointing, here. So the thing that's keeping him from pitching is his medial elbow, but he has the lateral elbow.
There was a couple of cuts where it was not as robust, but go back.
MCL?
Yeah, the MCL. Go back to the because this is hard to interpret on the MRI, especially with the plane. Depending on the plane, go to the sagittal. Where was the line? You had a line.
Oh, this one.
So the more anterior, yeah. So the more anterior, on the more anterior you are on the, then you can get a little bit more of the anterior band. But
Is this Dr. Grant?
it's fine there. Keep going on the corona. I don't think so. There looks like a little undersurface lift out there, and that looks not great. The last part. Okay.
Summary, this is a 19-year-old male right-hand dominant collegiate pitcher with right elbow pain. Got this partial proximal MECL tear. He's failed non-operative management, capitellar OCD lesion, and cubital tunnel syndrome with a subluxating ulnar nerve. So, I guess, for the consultants, like, what would be your treatment plan? Patient, how would you position the patient, your operative sequence, and MECL repair versus reconstruction graft choice?
Let's start. So for me, I would do his MRI. I really would like to sew down that lesion, drill behind it and sew it down, because it looked like the cartilage flap was attacked. So for the lateral side, I would like to sew down that lesion. On the medial side, I would, do an open approach. I'd like to do the OCD arthroscopically. It's less morbid. It's hard to get all the way over there for the medial side.
I think it's hard, whenever we're out of time, but it's tough. It's so much going on in this elbow, and also this is a kid who still wants to pitch. It's a lot of surgery, for somebody who still wants to play competitively too. So, but he's older, so his capacity for healing of that OCD lesion is going to be different than it would be for a 13-year-old. So ultimately, with his lateral side not being as symptomatic for him at baseline, I feel like I kind of wanted to take a relatively minimalist approach for the capitellum.
Like do nothing?
And, well, not quite that minimal, near minimalist. So
Behind it?
just an arthroscopic debridement alone. But that becomes difficult because it's a relatively anterior based thing, which I thought would be pretty difficult to access with them in a supine suspended position. So I actually scoped lateral decubitus first and then repositioned to get to the medial elbow, which I haven't done before, but I was very thankful that I did it in this case, which logistically is a little bit challenging, but was helpful.
I think I would go for it, but I think I would have done the MCL first. And the reason is because now I'm going to offload if I was going to sew it down. Was it a flap or was it, I guess we'll see. I mean, you got to assess it. So I guess if I do the MCL first, then whatever I'm going to do on the lateral side has been offloaded because I've repaired the medial collateral ligament. And just assess it. If it's a flap or something that I can sew down, I'd sew it down. If not, then it's a small lesion to breed.
open dissection more difficult because of the soft tissue swelling because of the fluid or not really?
No, not really, because to me, the lesion was pretty fragmented on the MRI, so I didn't feel like fixation was an option I was going to consider. So debridement was the plan. So it was fairly quick. So the scope portion was and because I was doing it lateral to cutis made it a lot easier.
Yeah.
So that was fairly quick to do.
Yeah.
And it was pretty straightforward to do open.
You have tons of these athletes. Top velocity, 85. He's 19. He's junior college. How hard do you go in the initial conversation with this kid about? Yeah, like do you have that conversation, or do you say they don't want to hear it at this age anyway? I just do the best I can for the elbow and move them along.
It's a little challenging because you're never going to convince them of that. And honestly, there are so many opportunities for them to keep playing, and some of them, even if they're not going to play Major League Baseball, they're going to play an independent baseball, or they're going to play town baseball. So there are plenty of opportunities.
They're gonna play either way.
I do talk to them about how long you're going to keep doing this, what's your plan. Okay, if that doesn't work out, what are you going to do? And then, I'm still going to keep playing town. I'm going to be as competitive as possible, as long as possible. Then I kind of treat them all the same.
So I like this quote. This is by Omar Bradley. He talks about amateurs talk strategy, professionals talk logistics. And so I think I was very much an amateur. I would scope the elbow for the OCD. I would fix, repair the MCL. But then professionals like Dr. Camp, they talk logistics, and they really talk about like the different like strategies of like how they're going to accomplish this procedure. I don't know much about Omar Bradley, but he's a general in the Army. So if I offended anyone, So this is Dr. Camp's operative plan. Part 1 going lateral decubitus, elbow scope, debridement of the OCD lesion and loose body removal, and then turn over the room. So turn supine, reprep, redrape. He goes to the second room to do a shorter case during that time. And then part 2 is going back supine, do the ipsilateral palmaris longus harvest, ulnar nerve decompression, MUCL repair with reconstruction with the palmaris longus autograft, and then your ulnar nerve transposition. So really thinking about like the logistics of this procedure, I think were like more important than actually doing the case itself.
Are you using autograft universally, every patient?
Yeah, for a competitive athlete, yes.
TJ, did you think that was mandatory, or is that like something where if you didn't do a TJ on this kid, you would just be kicking yourself? Because it was more like a partial humeral side, and it would seem like a less severe lesion.
Yeah. So the problem is, his symptoms. I mean, he's rested forever, and his exam was very clearly localized to his medial ulnar collateral ligament.
Got it.
The other thought is if you say, well, we'll try a smaller surgery, see how that goes. If that doesn't work, then career's over. If he has 2 surgeries, his career's over. High chance that it's over anyway. He does 2 surgeries and it's definitely over. And there's actually, because this is so common that, this will now be considered, they'll say, oh, he had a Tommy John surgery. Every scout in the future will just say, not realizing that he actually had a lot of other big problems. So this is kind of for these elbows, I prefer one surgery.
And signed baseball cards from all these players, just in case any of them, they're all going competitive. So.
This one's not good. This one's why are you kidding me?
Use this card as a bookmark.
If you're not in the 92 mile an hour range,
So elbow scope, lateral gutter and radial capitellar plaque excision, and then a debridement of unstable capitellar OCD lesion to stable edges with subchondral bone bleeding response. And then we've turned supine, did the ulnar nerve decompression. You can see that MUCL here, those tagged for the repair. And then suture anchor at the sublime tubercle for distal fixation of the MUCL reconstruction. And then the Dr. Camp's anatomic MUCL reconstruction with repair with internal brace augmentation. And so he followed the Mayo Clinic accelerated UCL rehabilitation protocol, I think for like the residents and fellows, really like taking advantage and downloading all these protocols before you go off into practice. Super helpful. I don't have any like specific articles for this, but Dr. Camp has some excellent articles on like elbowscoping, like he has a 3-part like series on like the basics of elbow arthroscopy, and then he has like a VJSM kind of like video as well as technique on this